So this is a 52-year-old male gentleman met with the road traffic accident and sustained injury to the thigh with fractured distal femur, which is compound grade 3B, having the transverse wound over the anterior aspect of the knee in particular and distal thigh. There was bone loss of 5 to 10 centimeter with a small distal fragment extending to the trochlea. He visited a hospital where the serial debridement and dressing were done for about 1 month and long leg splint was applied. So this was this initial scenario with X-ray. So after 1 month, wound was healing, but he had discharge. So visited some other hospital where the external fixator was applied and antibiotics and cement was inserted. So this is the X-ray after 1 month of the initial injury. Any comment from the panelists at this juncture? Yeah. Okay. So after the 2 months, wound was healed. So the surgeon removed the external fixator after 2 months. But this wound cement spacer was placed in situ. Any comment at this juncture? Okay. So after the 4 months, this was the X-ray. 4 months after the healing of the wound cement was removed and bone graft from the anterior spine was put on the fracture site and limb reconstruction system was applied with diphysial corticotomy. So this was the X-ray at the 4 months after the injury. And subsequently, after 3 months of LRS sitter application, dissection was started at the corticotomy site, which shows the corticotomy site is being dissected and gap is relatively busy. Subsequently, at 1 year after the injury, the corticotomy site is being dissected, but it doesn't show any callus formation. Fibular, then surgeon applied the fibular graft over the fracture site with LRS fixator in situ. He has also done the anterior crest bone grafting at the fracture site, but the gap was at the corticotomy site was persisting and there is non-union at the fracture site. These were the subsequent X-ray after the 6 months of fibular bone graft. So this non-union is still being persisting and there is persistent gap at the corticotomy site. In addition to that, pin were loosening. So subsequently, the distal femur fracture site was failed to unite and there was the displacement of the fracture and the corticotomy site is also not uniting yet. So surgeon removed the external fixator and in the desperate attempt he has applied 3 enters nail to the fracture site. So any comment from the panelist at this juncture? So this was the presentation and the patient presented to us. Patient was having the multiple scar marks of the pin and external fixator and original wound over the anterior aspect of the knee, thigh, involving the quadriceps tendon, and there was persistent non-union and flexion was only the above the drop-off movement about 10 degrees. There was cross wasting of the quadriceps both anterior-superiorly with the spine and one side fibula was already been used for the bone grafting. Patient was not able to bear weight, so he was working with the caliper support. There was poor bone stock, and these were the X-ray about 1.5 years after the initial treatment. So the under snail was jutting out from the anterior aspect of the fracture, and there was persistent non-union and poor bone stock. So what could be done at this juncture? I can initiate the discussion. Panelist. Okay. So the subsequently patient was managed with a deeply inserted interlocking nail and supplemented with the medial buttress plate. Distal non-union site was bone grafted. The patient was allowed to be admitted with the worker support. So what do we expect from this treatment at this juncture, and what type of the prognosis we can offer to the patient? Subsequently, follow-up, post-op follow-up with the sequential X-ray shows the corticotomy site is consolidating, and distal femur site is also being consolidating, and patient is able to be admitted after 1.5 years of the surgery. The bone marrow was infiltrated 2 times at the distal fracture site, and these are the subsequent X-ray, which shows that eventually the nail broke at the distal fracture site, but fracture was uniting at 2 years of the follow-up. Any comments from the panelist? So the take home for the compound fracture, the timing of debridement is most crucial to remove the contamination and prevent the infection settling in. So first aim should be the conversion of the open fracture to closed one. Then only the things will start. So the focus should be on the soft tissue repair, then for the treatment of the fracture per se. The size of the for the compound fracture, the treatment starts with the conversion of the open fracture into closed one. Size of the distal fragment is most crucial for the fixation as well as for the healing, as most of the healing comes from the distal fragment. Distal fragment should not be used for the temporary fixation, but it should only be touched while we are applying the definitive fixation, because if the infection settled in, that will eat out the distal fragment, and subsequent fixation and wound healing will be severely going to be affected. Regarding the approach, if there is condylar convolution, better to use the subversus or the swashbuckler approach that gives the good exposure to the condyle as well as the shaft. Supplemental fixation is undesirable with the low profile list. Bone grafting is often required in such cases. To bridge the gap, many options are available in this track, but however, the fibula is readily available and most reliable option. Use of local antibiotic can prevent and help in the eradication of the infection. Supplemented osteoinduction by bone marrow or the bone morphogenic protein may help in healing. Extension of fracture in trochlear area, the fat pad, patella, quadriceps determine the future range of movement of the foot. And finally, and most importantly, these fractures are known to go into the delayed union, so the time is very much important, and this requires patience and compliance on the part of the patient also, and protected mobilization to prevent implant failure in this high stress. Thank you very much, and thank you for your time, and thank you organizers for providing me the